can see those ribs expanding equally on both sides. You can do it up top as well, so take a deep breath in. So pretty close to equal on both sides. All right, so that would be his rib expansion. Like I say, that's the other thing that you really want to try and do for your movement patterns. Okay, is make sure that the ribs are moving properly. Right, sit right back onto the bed. So yeah, sit right back. That's perfect. Okay. Normally my bed's a little bit narrower than this, so I can get across them easier. Like the cervical spine where we did the compression, we did it through the top of the head. Okay, so we're trying to push down onto the spine and compress everything. That's testing the joints, but in the spine it's a little, again, more complex because what do we have? We don't only have our joints there, we have these discs sitting in between the vertebra, okay? And we have these nerves coming out at each interval between the vertebra. So when we compress, we can be compressing any one of those type of things, okay? So in the neck, when we're compressing, we could be compressing a disc, we could be compressing a nerve in particular. Usually it's not the joints will tend to slide a little bit, but if they're stuck, they won't. So compression will tell us perhaps there's a nerve problem, perhaps there's a disc problem, perhaps there's a joint problem. Something doesn't like being compressed, and so think about the structures you're compressing. If in the neck, we said when we do compression, if it recreates some pain down into the arm, then it's going to be a nerve, right? We're compressing onto a nerve. In the thoracic spine, things are a little bit more bound down. Our nerves, and we're not going to do the same kind of muscle testing, the myotomes and the dermatomes in the thoracic spine, as we do in the neck area, because in our thoracic spine, basically, the pattern of pain referral will be along this way, okay? So there is a diagram of that, and another page or so here again. Okay, last page. Okay, the very last page. The thoracic dermatomes, that's the area of pain referral. So has anybody here ever seen somebody with shingles on their thoracic spine? If you see the shingles, you'll see the rash going along in that dermatome, okay? And that's because it is the nerve that's affected, so the rash just goes all the way around in that dermatome. Okay. All right, so when we're compressing, again, we're compressing a few different structures. We're compressing the joints to a certain extent, but more so the discs and the nerves, all right? So to do it in the thoracic spine, I just come on top of his shoulders and then push down. Okay, so that would be compressing as much as possible. It can be a little uncomfortable, so just warn people, I'm just going to push down on your shoulders. And if they're tight in there, it might be uncomfortable. It feels good? Okay, that's fine. Squish you all together. Okay, so that would be compression. We don't really do distraction, because normally we do compression and distraction. But we don't normally do distraction because it's very difficult to do in the thoracic spine. You can't really kind of stabilize one end, put a harness around the neck maybe, and then pull on their legs or something, but you really can't get things stabilized enough to do it. Whereas in the lumbar spine, we can do distraction because we can use this as a counterbalance weight. Okay? So we don't normally do distraction here. There is a method of doing it that we do in physio to distract, but it's pretty bulky and difficult. Okay, so what we're going to do is, the next thing is to test the T1 nerve root. Okay, so T1 comes in through here. And one way to put it on a stretch is to have the patient take their arm and put it behind their head and then reach down their back, and then you pull back on their elbow. Now be careful if they have shoulder pathology, right? They do, it may aggravate the shoulder. But what we're looking for here is that it reproduces the symptoms, all right? So for example, it could reproduce pain in that T1 region. So that it's a relatively common thing. It often gets missed. And so it's just a clearing test. If they have pain up in here, just really easy to do. Get them to bring their hand behind their head and then pull their arm backwards to put it on a bit of a stretch. Bilateral arm raise. With this one, all you're going to do, and normally I'd have like take the t-shirt off the end, but it's fine. We've seen his tan, so. What you're going to do is take your arms forward. and then just lift all the way up. Okay, going all the way up. Now, if you remember from our shoulder assessment way back when we first started learning and looking at things, and then down again, is that when we looked at this motion, we were looking for movement of the shoulder blades to make sure that the shoulder blades were sitting well on top of the thoracic spine, that they were moving equally, that they're not winging out. We can look for the same kind of thing. We're also looking for this for extension at the very end of the range of motion. Okay, so when we take our arms up, the very last little bit of extension should be coming from here. So if somebody comes in and says, yeah, I only get the pain when I'm reaching up into my top cupboard. Well, have them do this and see if they're actually extending in that position. Okay? Are they extending? Does that recreate your pain? All right, now we're going to do, has anybody ever heard of thoracic outlet at all? Okay, a couple of people. Thoracic outlet is a condition where a part or some of the brachial plexus, you guys remember what the brachial plexus is?
Yes. A nerve.
Anybody want to volunteer?
The branch-ready nerves move into the arm and
Yeah.
a whole bunch of
stuff up there. Basically, it's a plexus of nerve and vessel, okay? So there's artery and vein in there that is created by, in particular for the nerves, and that's what we're testing here for the most part, is the nerves that come off the cervical spine and the T1 nerve root, okay? Those come together and form and reform in various bundles to create the peripheral nerves that run down into the arm. So they come off of the neck, they come underneath or through those scalene muscles on the side of the neck, they come over top of the first rib, underneath the clavicle, around the pectoralis minor, down through the arm, and that's where they start to differentiate into the various ones. People who have pain that refers down into their arm, or if they have sometimes even carpal tunnel syndrome, it may not be coming from the carpal tunnel, it may be coming from up higher here. Okay? So a thoracic outlet test is always a good idea to see if it A, recreates the pain or symptoms, so it could be anything from numbness or tingling or pain down somewhere into the arm, or it could be weakness, but you're not going to necessarily detect that. Okay? So if you have somebody that comes in, say, with carpal tunnel, you should really be doing this test to clear the actual thoracic outlet area. There's some very complicated tests that you'll learn in a more advanced situation, but for now we're going to use these basic ones that give you some idea as to if you put that brachial plexus on stretch, is it being caught up somewhere that's not moving easily, and does it recreate the symptoms? Okay? So what we're going to do first off is I'm going to take the arm and take it back into extension. So we've got external rotation, so I'm rotating. Oh wow, see, I've got a lot of external rotation in there, okay? And then you're going to look towards your arm, okay? And does that give you any problem at all?
Really tightness on the knee.
Okay, so he's got a little bit of ulnar nerve kind of stuff going on, okay? Turn and look towards the other side, just as a, does that change it at all?
Yeah, actually hurts my elbow.
Okay. All right, sorry, I might be cranking on your elbow a little bit too much. Let's just take it there. Okay, does that give you elbow problem still?
Yeah, it feels like a nerve.
Yeah,
I
okay.
do have
So,
injuries
do you?
with that.
Okay,
Yeah.
let's do it on the other side. I don't want to flare anything. Okay. All right, so turn and look towards your arm. And does that do anything on this side? So we've got a positive on the right. Okay, so there's something going on there. Right, then we're going to take the arm up into abduction. And again, try and take him back a little bit. Right. And then turn your head away from the arm. And does that cause anything there? Okay. So what we're doing by the two different positions is we're testing two different parts of the brachial plexus. Okay, so the normally when we have it down lower, we're testing the upper part of the brachial plexus. When we have it up higher, we're testing the lower part of the brachial plexus. However, he had symptoms down into his ring finger when we were testing what normally would be the upper part of the brachial plexus. The ring finger is more that C8 type of thing, so the ulnar nerve is created by C6, 7, 8, T1, oh sorry, 7, 8, T1, I think, so. Okay. So what we're looking, yeah?
Do you always check if you find something going on in one shoulder? You're always going to test the other one?
Yeah, it's a good idea because you want to know, is it something that is, you know, normal for them, so to speak? Because when you do these tests, some people will say, yeah, this feels tight, kind of thing. Okay, so you want to compare it to the other side. So are they balanced from side to side? Is there something more going on one side than on the other side? Okay.
Is it typical to be tight when you're skating on both sides? I guess
it's not unusual, yeah. But usually if you have any kind of spinal pathology, in particular, the scalenes often go into spasm, and they will be tighter on one side than the other usually.
So you would potentially find something.
Yeah. Yeah. Okay, so we don't know actually what's causing the problem there. It could be the scalene muscles, it could be the rib is sitting up a little bit, okay? It could be the pectoralis minor is really tight, and that's putting pressure onto the nerves. We don't necessarily know exactly what it is. So what then you can do is go in and palpate. Are the scalenes tight in there? Do you guys remember how to find them? We learned that last year. Is the pectoralis minor tight? Is the first rib sitting up? So we found the first rib at the front is the easiest place, but to find it at the back, all you need to do is come in just right where the neck forms the shoulders, okay, and push down in there. And make sure you're behind the big musculature there, okay, and just right there. You're up a little bit on the right side of that tender there.
Yeah, actually, that's exactly where it blew.
Is that right? Yeah.
That's all off the motorcycle and bang.
Nice.
Yeah.
Yeah, okay.
It's way down.
Yeah, his first rib is up a little bit. And if anybody wants to come behind me, you might be able to see this. It's not huge, but it's up a little bit. So I'll just leave my fingers there. So you can see how far my left finger goes down. And you can see where my right finger is. It's a little bit higher. Okay. Can you see the difference on the camera?
Yep.
All right. So his right first rib is elevated a little bit, which could be coming from scalene muscles because they attach into the first rib, or it could be coming from a joint dysfunction where the rib attaches to the first thoracic vertebra. We'd have to go in and test that, or for you guys, really, okay, then you look at that first rib, it's up. Maybe you want to treat those scalenes and see if you can get them to relax a little bit. So some tuning knots and acupuncture, that type of thing. Okay.
Jackie, is that the cause for his vertigo?
The tightness in through here,
Yeah.
doubtful because it's so far down. Now, is it secondary? He's had an injury, so I think it's probably more the injury that's creating it rather than secondary to this curvature here.
Oh, okay.
Yeah, I would think. The curvature, again, I don't know what the cause of that is necessarily. I haven't gone into feel for muscle tightness or feel for the joint movements and stuff. But there could be just an abnormal joint movement in there. Okay. So elevated a little bit on that right side. Okay. That's not something that I've asked you guys necessarily to look at, but it is, you know, sometimes a useful tool to see. So it's easy enough to find. Just be careful when you're palpating the pillow if you're going to do it, because it is tender. Okay, so the first rib is normally tender. To push onto, it's bound down there with a lot of muscle and stuff, and it's usually a tender spot, but he's definitely on that right side. Okay. So then the last one that we're going to do that we haven't done before, we did the slump test with Babinski, so we can go through that again. Excuse me, when you guys are practicing, I'll come through and make sure you're able to do it. This is the rib springing. So I'm going to have you lie onto your tummy for me. And you can just turn your head to the side if that's more comfortable. Okay, and then all I'm going to do is just take my hands and just spring on the ribs. Compare one side to the other. They should be kind of nice and bouncy kind of thing. They shouldn't feel stiff or hard, all right? And it shouldn't recreate pain. If you recreate pain with this, it generally means a rib pathology. So you may have a fractured rib, you may have a costochondral junction thing. Sometimes even if you have a problem right at the joint between the rib and the vertebra, that can cause pain there too. Okay. So just doing rib spring, and it should feel nice and equal side to side and nice and springy side to side. The patients go, oh, more massage.
Okay, thank you.